Hi, I'm Dr. Kivett from Santa Rosa, California, and I have certifications in plastic surgery as well as dermatology and other fields. And I'd like to speak to you today about the skin cancers present in the hand and arm. My background includes that of hand surgery fellowship with a board-certified orthopedic surgeon and a board-certified plastic surgeon, both of whom devoted their careers to those of surgery of the hand, the forearm, and the upper arm. Today we'd like to talk about the cancers called basal cell cancer, squamous cell cancer, and melanoma. Those are the most common of the cancers. There are certainly others, but those are the major ones. I've dealt with cancers for years, written various papers and chapters and portions of books on those. Basal cell cancer is the most common human malignancy. In the United States, about 3.5 million Americans a year get basal cell cancer on all the body parts. Squamous cell cancer comes in second with 1.5 million cases per year of skin cancer. And then melanoma is seen in about 100,000 patients per year in the United States. Of this category group, basal cell carcinoma rarely kills a person, but you have to have great respect for it because it does have roots and tentacles. Squamous cell carcinoma can be problematic, particularly in people who are immunologically compromised, whether being diabetics or whether taking cortisone medicines for other conditions, such as after having a transplant or having some autoimmune disease. Melanoma is the one that has really scary problems. And so in this country, one person every hour in the United States does not get melanoma. One person in the United States every hour dies from melanoma. So when we see these people, we usually do biopsies first, and then once the biopsies are carried out and interpreted in pathology laboratories, then we go ahead and fairly quickly institute treatment. One common method is with Dr. Mohs technique, MOHS. I worked with Dr. Mohs in the 1980s and published with him, and we used to do 70 cases a day of skin cancer. He began doing this work in 1935, and he worked until a very advanced age, somewhere in his upper 90s, 96, I believe, and treated many thousands of people, probably 400,000 people. And so the techniques that he described helped remove as much risk from skin cancers, helped reduce the recurrence of skin cancers generally, helped introduce new techniques for both removal of cancer and repairs of cancers, defects. And recently, melanoma has been introduced into the pantheon of treatments using some of his techniques, particularly the superficial melanoma in situ, meaning in Latin, in its place, high up in the first layer of the skin, the epidermis. There have been some additional technological advancements as well, beyond just standard surgical ones. A fellow named Don Morton at UCLA was there in the 70s and 80s, and I was there at the same time. I did not meet him, but his influence over the whole field of skin cancer was pervasive. He was able to demonstrate that in many cases, if there were cancers that looked like they may have spread, then he outlined the tenets of the principle of sentinel lymph node removal. In other words, if you have a sentinel guard that stands at the guard gate and holds the rifle, that sentinel then did not allow people by unless there was some resistance. And so in certain cancers, including squamous cell cancer, and even more importantly, in melanoma, these cancers may end up being studied also by removal of a single node, lymph node, that is identified by usage of a very safe radioactive, briefly radioactive chemical that localizes the precise area where that sentinel node is found, and if removed and is negative, the chances of there being any more cancer in the patient at that time and most likely later on is very, very low. However, if the sentinel node is positive, then more lymph nodes may be taken out and examined to see if, in fact, the tumor has been stopped by that sentinel node permanently, or in fact has spread into the remainder of the nodes, which then changes the whole game in terms of patients needing radiation, chemotherapy, immune therapy, and so forth. Standard methods for removal of cancers are usually, however, simple excision of those under local anesthesia, and then these tissues are studied and a report is issued about 2 weeks later. With Mohs surgery, however, that very day there has been enough removal of cancer and immediate examination under the microscope that the patient is repaired the same day and is reassured with a high level of confidence that the cancer is gone. Now, a skin cancer does not arise in a sea of virgin skin. Skin cancer almost always arises where there has been significant sun damage. And so, frequently to my practice, once I remove cancers, then afterwards I use one of a number of immune stimulants to the area to selectively destroy any remaining cells in the region that may be even considering becoming cancer, much less being superficial cancers. So there's a great deal of valuable technique and technology and study in this whole area that allows us to remove cancers. And then the repair processes are described in other of these videos, but simply we follow the reconstructive ladder. That is to say, sometimes we will simply let the wound heal on its own with bandages, and they heal fine. But other times we do suturing techniques, close the skin side to side, or to move nearby tissue over the area, or to bring in other tissues from other body parts into the area, depending on the intensity of the change. So if you know someone that has a problem with this, or if you have a friend or neighbor who's interested in the topic, please let them see this. And if you'd like to leave a question or comment, please do. Please give us a thumbs up. And as always, please subscribe so that we can continue to make these educational videos. Thanks for listening.